Hi everyone, this is Jack from Singapore. Thanks for attending this event. This is the Asia Pacific Society of Cardiology webinar hosted by APSC and endorsed by ISCP. And we have faculty and very esteemed faculty in cardiology and ID across the region to share experiences. And our guest speaker today will be Dr. Zhou Ning from Wuhan, China. So he is I heard a star cardiologist, up and coming rising cardiologist, one of the star young cardiologists from China. And he led the front fight against COVID, treating his cardiology patients as well. He's from the Dongji Hospital, Hua Zhong University of Science and Technology. And I managed to dig this slide out, Dr. Zhou Ning. I wonder whether that's you. This was publicized in the Chinese news. Heroism, well explained by the Chinese medical workers. Prof. Zhou Ning was one of those that got infected while I was working and seeing this group of patients very, very early. And his tips and tricks on how to recover from COVID went viral, I heard. And that's him in this particular report. So he's going to share with us not just his experience in treating patients, but how to get well if you get COVID. Professor Koji Hasegawa is from Kyoto, Japan, and he's our next esteemed faculty from representing both APSC as well as ISCP. He's immediate past president for ISCP and is, as you can see, is a very esteemed professor representing a lot of boards across the region. Dr. Ling is a senior consultant ID physician at NCID. NCID, for those who are not in Singapore and not aware, is our National Center for Infectious Disease. This is really the epicenter treatment center for Singapore. And she leads the ICU team in treating infectious disease at Tan Tock Seng Hospital as well. And this NCID was actually built out of the fear and the need that we saw post-SARS in 2003. So Singapore, like China and Hong Kong, had SARS. And this new building was built because we're expecting the next pandemic. Dr. Lam Ho is a good friend of mine. We have known each other for many years. He's an interventional cardiologist from Hong Kong. And he's very active, always doing crazy stuff in the cath lab. But recently he shares with me that he's very interested in doing all these educational forums through webinars. And I'm doing one more. I just did one with him the other day on the transcontinental COVID CBM sharing. I'm doing one more with him tomorrow again, I think, on complication sharing, if I'm not wrong. So, sorry, next month. And that's for introduction. I'm going to stop my sharing of the slides. There is a Q&A. So feel free to enter your Q&A. We're going to group this question. And we're going to take a quick Q&A after Dr. Zhou Ning's presentation, followed by Dr. Ling's presentation, then a summary Q&A. We'll try to address as many of your queries as possible. Tell us what you think. We are calling for feedback, and there will be a feedback form that will pop up. And your feedback will help us structure the next series of webinar that we think will be useful across the region. Last but not least, I'd like to thank Roche as a sponsor for helping coordinating the logistics for some of this event and for pushing for this education forum to continue. So I'd like to thank Roche for kindly sponsoring this event and gathering our stakeholders across the region. So without much more ado, we'll get Professor Zhou Ning to start sharing the slides. Thanks.
Okay, it's my time? Good.
Yeah.
Okay.
So you can share your slides now.
Okay, thank you so much, Dr. Chen, for your nice words. So I would like to share my screen first. So can you see it? Okay. As mentioned by Dr. Tan, so I'm a cardiologist from Wuhan, Tongji Hospital. And yeah, he just mentioned I was infected in the very beginning of this outbreak of COVID-19. Actually, that's a very sad story. I don't want to mention it, but fortunately, I survived. And yeah, and after I get a 2 weeks quarantine, and then I returned to the ward of the COVID-19 patient. So it's my great honor to be here and to share some experience, is bad or is good. So and share it with these outstanding colleagues from all over the world. So the title of my topic is the clinical characteristics and management of the COVID-19 patient, especially focused on the management of the very severe COVID-19 patient. So this is my self-introduction. And first of all, I would like to introduce my hospital. My hospital is Tongji Hospital in Wuhan City. So it was founded since 1900 by a German doctor. And we have 3 campuses and over 60,000 beds and 10,000 medical personnel working in my hospital. And we have 62 clinical departments. And also it's ranked of the top 10 hospital in China. So where I work is this campus is optic body cameras. So it have 1,000 beds in this campus, and recently it was designated as an exclusive hospital for the COVID-19 patient, especially for the severe COVID-19 patient. So I have been working here for over 2 months. And yeah, Wuhan may be not so famous as Tokyo, as New York, as other very big city in the world, but now I think it's very famous because it was the epicenter of China of COVID-19. Actually, Wuhan is located in the very center of China, so it has a population over 12 million, and because it's very center, so it's a commuter area of China. Due to the outbreak of COVID-19, it was locked down on January 23, and we're so happy to share this news with you that our city was lifted the lockdown on April 8, just 1 week ago. So far, there are more than 83,000 accumulated cases in China, and unfortunately, we have over 3,000 deaths so far. Most of the cases came from Wuhan city. We have over 2,500 deaths in the epidemic of the COVID-19. And I would like to share with another bad news with you that we have a lot of medical staff that was infected in the outbreak of this COVID-19 epidemic. And unfortunately, 61 medical personnel died in the, passed away in the epidemic. It accounts to the mortality rate of the medical personnel is around 2%. That's a great loss of Chinese medicine. And this is a clinical characteristics of the COVID-19 patient in China. It was published in January, in the very beginning of in a very early stage of the epidemic. Someone said that the coronavirus only infected the elder. That's not true, as you know. From this chart, we can see that people aged from 0 to very old, like 65 years old, they are all very susceptible to be infected by the coronavirus, and especially for those people aged from 15 to 65, they account for the biggest proportion of the infected patient, and male account for a majority of the infected patient, and the median incubation time is around 4 days. And most common symptom of the patient is fever, and the body temperature was not so high. It's only 37 to 39. And most of the patients have a dry cough. Also, some of them have the sputum. For those who have a shortness of breath, that's not a good sign. That means it has a very high possibility to develop into a severe or critical severe type. Also, around 1/4 patients have a coexisting disorder. For our cardiologist, we are very interested in the patient with diabetes, hypertension, and chronic heart disease. This is a very early data. They found that around 50% of patients have hypertension in the COVID-19 patient. But according to our observation, because I worked in the ICU ward of the COVID-19, I found that around 48% of the patient with a severe COVID-19 patient has a coexisting hypertension, and around 14 patients have a coronary heart disease. I mean, just for the very severe COVID-19 patient. So that's very high. That's a very high proportion. And also the complications include the LDS and the pneumonia. Most of the patients have a symptom or signs of pneumonia is account for 91%. And this death rate actually is early stage, in the early stage. So it's only 1.4. Actually in China, so far the mortality rate of the very general COVID-19 patient is around 4 to 5%. But for the very severe patient, the mortality rate is much higher than this. So these two videos showed that a very typical change of the radiological characteristic of the severe COVID-19 patient. Look, the lung lesion is very significant. And this is another summary of the report from published in February, including more cases, around 72,000 cases. So the person aged from 30 to 90 account for the majority of the infected person, and 81% of them are mild. Unfortunately, around 20% of the patient will develop into severe or critically severe patient. For those severe cases or critically severe cases, the mortality rate is extremely high. It's around half. That means half of the patient will die after the infection of COVID-19 if they are a critically severe type. And for those very old, the mortality rate is also very high. It's around 50%. So this is a report of the health personnel infected ratio is around 3.8% of the patient of the medical health doctors, and 63% of the medical doctors and nurses who was confirmed infected by COVID-19 who was working in Wuhan. Because in the very early stage, we don't know what is the pathogen, what is the origin of the infectious disease is, and we even don't know how infectious the virus are. So at that time, we don't have enough PPE, and we get a lot of medical personnel were infected at that time. And 48% of these infected medical personnel are classified as a severe or critical severe type, and 61 deaths. So this is a matter of great concern from our cardiologists. So for those non-survive, this was published in JAMA in March. So for those non-survivor patients with COVID-19, their hypertension is account for 48%. The diabetes is 31%, and the coronary heart disease is 24% in the deceased COVID-19 patients. That's very, very consistent with our observation in the ICU ward in my hospital. And if the patient have a very high troponin, that means the patient have a myocardial injury. So in this case, the mortality rate is very, very high. So 46% of the non-survivor has a positive troponin. And we conclude that there are some clinical characteristics of the severe and the critically severe patient with COVID-19. The first one is the distance. That means around 20% of patient is severe type. And then it's a high mortality. 60% of the patient, that means the severe patient, will die. And in the patient, for those severe or very critical severe patient, most of them have a multiple organ injury.
So, Dr. Zhou, I think we're losing you a little bit there on the internet.
What? Pardon?
Yeah. So you can continue again. Just now there was a.
Unstable connection. Okay.
Yeah. Okay.
So for the management and the control of the epidemic in China, the first step is test to find out the source of infection. That's the most important. So we need a lot of virus test kit to find out this infected patient. Secondly, the isolation. To isolate all of the confirmed cases or the very highly suspected cases, cases to isolate them to cut off the path of infection. So below I provide a link to help you to find out the experience and the guideline in China we followed to management for the management and the treatment of the COVID-19 patient. It was published by the China National Health Commission. And for the treatment, as you know, we don't have very specific and very confirmed effective antiviral drugs to fight against the coronavirus. So most of the treatment are general treatment, including the rest monitoring and the oxygen therapy. And because in China we have a lot of mild type COVID-19 patients, so we give them some traditional Chinese medicine. And this is the antiviral drugs we used in the world. But so far we don't have very solid and very strong evidences show that some of the antiviral drugs is very, very effective for the coronavirus. So for those who develop into a very severe COVID-19, what should we do? Most of the most used and most common used method is to support the mechanical ventilation for this kind of patient. But what if the patient still have a very severe hypoxemia on ventilation? So we don't have many choices, right? And some of the patient was needed the monitoring and the management in the ICU ward. In the ICU, that's where I worked in the hospital. So for the treatment of the severe patient, we need the respiratory support, including non-invasive and invasive ventilation, and also the immunotherapy like a systemic steroid, and the blood purification, circulation support, and finally we need the ECMO support. So I would like to share, I will go through very quickly for a very critically ill case. So this patient is 50 years old, is male, Mr. C, admitted on the February 11, 2020. So the chief complaint of this patient is fever for 11 days and short of breath for 2 days. So this is a physical examination of this patient, shows that the SpO2 is very low. That's a very dangerous condition. And the coronavirus, he get a very positive coronavirus test. So this is a CT scan image video of this patient. It looks like the lung region is very, very bad. And the lab test showed he has a very low lymphocyte proportion. So as you know, the lymphocyte proportion is a very strong biomarker for the outcomes and the prognosis of the patient with COVID-19. If the lymphocyte is very low, that means the outcome of this patient is not good. So be very, very careful about this kind of patient. And also we find a very low, a very increased NT-proBNP. That means that's a biomarker of heart failure, and a high troponin. And that means the patient have a myocardial injury. Also, the ejection fraction is very low for this patient. So that means this patient have a complication of heart failure and a heart injury. But we give some very general treatment for him, but the hypoxemia getting worse and worse. This is X-ray just took 2 days before he was transferred into ICU. So we give some additional treatment in ICU for this patient, including the intubation and the ventilation, and also the prompt position ventilation to help him to overcome the hypoxemia. But his oxygenation index is still very low. It's only 95 millicuries. So you know, as a normal or healthy person, his oxygenation index should be higher than 300 or 400 millicuries, but his is only 95. It's a very dangerous condition. And also the ABG shows a very low pH, low PO2, and low SpO2. So we don't have much choice for the treatment of this patient. So after a very comprehensive discussion, we decided to do the implementation of ECMO for him. So that's Feb 18. And this picture, the left one, the picture just took a couple minutes after we finished the implementation of ECMO bedside. And the right is shows that his SpO2 went up very quickly after the implementation of ECMO. So this is the initial parameters of the ECMO. And during the treatment and monitoring in the ICU, he's getting much better. So here shows the ABG shows that his PO2 goes up very quickly, and he get after the treatment of the in the ICU, his coronavirus test shows a negative result for 3 times, and the total antibody for COVID-19 is positive. So these 2 CT scans showed before the implementation of ECMO and 2 days after, 1 day after the wean off of the ECMO, shows that his non-lesion getting much better. And we removed the ECMO on February 27. So this picture shows that he's regained his consciousness, and he says he looks very healthy here. Look, he was discharged in March 20. He can talk, he can walk, he can do something that the healthy people can do. So we are very happy and so proud for him. And this is summary of this case. We give the antiviral drugs, biotics, and steroid. And this is the duration he stayed in the ICU. And this is the invasive ventilation for over 11 days. And the ECMO continues for 10 days. So this is X-ray and the CT scan images for him before and after the ECMO implantation. So far, we have finished 5 cases, 5 ECMO cases, and 4 survived. Just 1 died of the cerebrovascular hemorrhage because even after a very strict anticoagulation, but unfortunately he has a complication of the bleeding. So 4 cases are male and 1 female. 4 cases is VBA ECMO and 1 VA ECMO. The average age is 55.6 years, range from 44 to 68. The died one, the death one is aged 68. And duration, average duration of the ECMO support is 11 days. So this is the 5 cases we underwent the ECMO application. So this first one, the 4 cases is already discharged, and this is a non-survival. So, and I would point out that the first 2 cases, I mean, to remove the intubation first, remove the ECMO first, and then executing. So that means these 2 is not awake ECMO. But for these 3 cases, they remove the intubation first, and then wean off the ECMO. So for these 3 cases, they are awake during the support of ECMO. So that's what I want to discuss is for those patients who need the ECMO implementation. I prefer to use the awake ECMO for him because of in our world, 64% of the patients who cannot expulsion after the invasive ventilation. I don't mean that the intubation is not good for those critical COVID-19 patients if they need mechanical ventilation. I mean, for those patients who need a support of ECMO, I mean, to use the ECMO earlier may be much better to use it later. Before they get a MODS, the ECMO implementation can save their lives. So that's what I would like to share with you, and I appreciate for the helps from the friends all over the world, and we get a lot of helps and guidance and instructions from overseas, and appreciate for the forgiveness for my family, because as Dr. Tan said, I was infected in January 21 after I did an ablation for a tachycardia patient, and I got a fever and cough and fatigue, and lie in bed for 4 days and get recovery, and then I returned to the world to take care of my patient. So I actually during the epidemic of COVID-19, I was both a patient and doctors, so I know something that the general doctors who don't know, because for those patients, I think they are the hero of my city because they fight against the coronavirus with their body, and we fight against the coronavirus with our drugs, with our techniques, and with our efforts. So I think, yeah, out of the road, the coronavirus is a very common enemy for all of us, for all of the world. So we should stand together and hand in hand to overcome this crisis. So thank you so much.
Thank you very much, Professor Zhou Ling. It was indeed a very remarkable lecture. It shows that you went through it, every part of the COVID experience. And I think I'd like to congratulate not just Wuhan, your hospital, the citizens of China, because they've shown the way for the world. You all had a huge surge, and I can see, and you can see clearly the data that the number of cases in China has really plateaued, so that you can reopen both Wuhan as well as the province. So congratulations. I'd like to take a pause here to ask some Q&A before we move on to Dr. Ling's question. So we have quite a few questions popping up while Professor Zhou was giving the lecture. So I'd like to group it a little bit, and I would like to start off with some question on medications first. So we are not experienced in, as far as I know, the summary is that none of the medication is really evidence-based. And China has some experience with some traditional medicines. Can I find out what traditional medicines? And there's also a question about your experience in hydroxychloroquine in cardiac patients, whether they do harm patients more than help them. So maybe I start with Professor Zhou first, followed by Dr. Ling on this question.
So thank you for your question. So as to the antiviral drugs we use in our world, I personally, I think the hydrochloroquine might help for those severe patients, because we tried these drugs in some patients, and we already sent a manuscript outside. It is still under review, but our preliminary data showed that this the hydrochloroquine is help for those very severe patients. It can decrease the mortality rate around 30%. So it's unpublished. So I can't say that it is not for the peer review, before the peer review. So that's our raw data I would like to share.
What do you observe? When do you stop it for your cardiac patients? What do you watch out for when you start hydroxychloroquine?
We checked the antibody and the viral test. We did the viral test, and that means compared with other antiviral drugs, the patient used hydrochloroquine, he has a much higher change from the positive to the negative. And also we test the concentration of the antibodies. They also showed a better result in the patient who received the treatment of hydrochloroquine.
So there's some viral, antiviral activity going on. Do you do an ECG serially for this group of patient?
Yeah, we did ECG and echo, both.
Okay, Dr. Ling, you have any comments about therapy-wise, hydroxychloroquine?
Yeah, so our experience with hydroxychloroquine really isn't that extensive, because I think we started off at the beginning of the pandemic more in favor of Kaletra and interferon. But having said that, right till today, we really do not have proven effective therapies. And the only reason why, as an ID group, we collectively decided to use, and again, it's physician dependent. So not every ID doctor is going to go up there and prescribe Kaletra or interferon or both to every single COVID patient they see. Yeah. So I have to say that our experience firstly was initially with Kaletra and interferon. Have we seen fantastic outcomes? I really don't know. Okay, as in, I don't think we've had patients that have done well, but we've also had patients that deteriorated on Kaletra and interferon. Okay, so in NCID, our approach really is that if there's a clinical trial for antivirals, we would prefer for these patients to be recruited into the clinical trial first. Now, only if they are not eligible for clinical trial, then that's when we start discussing with patient the option of Kaletra and interferon, especially if they are fairly early on in the disease process, so less than 12 days or so, because we had some data that had emerged from China, the recent NEJM study that indicated that Kaletra somehow didn't seem to have had significant benefit when compared to the placebo arm. And then hydroxychloroquine, really, we've only started thinking about it a little bit more seriously in the past month. And we've only started prescribing it on a very ad hoc basis, again, very physician dependent over the past 2 weeks. So I really can't say very much about hydroxychloroquine, except that say the patient is not eligible for trial and it's already week 2, week 3 of illness, and therefore we're thinking, well, Kaletra interferon may not work anymore, then maybe we might consider hydroxychloroquine. But if the patient is very old and has got cardiac risk factors and the QTC, is a bit borderline, we may not even offer hydroxychloroquine. So our experience with is not uniform. That's all I can say.
And there are a lot of questions about therapy. So I think people ask about antibiotic. I think azithromycin has been tried in combination, hydroxychloroquine or chloroquine.
Yeah,
there are comments about convalescent plasma as well. So I think the summary is that all these are not evidence-based. It's quite anecdotal. The evidence so far is quite mixed. The recommendation so far is that you want to start this therapy, it should be discussed in patient and probably started as a protocol so you can collect data and show whether it's useful in the future, including some of this traditional Chinese medicine that has been tried and used across China. I think we need much more data to show usefulness. I think we really don't know. I think what Dr. Zhou said is perfect. Beyond supportive therapy is Star Trek zone. I think we're not sure. So I want to move on a little bit. There's this question popping out about, I saw in Dr. Zhou's slide, hypertension patients consist of 50% of this group of patients. And what is your advice? Should this group of patients stop their ACE inhibitor because there's some association with ACE inhibitor use ARB as an entrance pathway for the COVID virus? I wonder whether Dr. Zhou or Dr. Koji has any comments or advice to the audience regarding hypertension and COVID. Dr. Zhou first.
I have some kind of slide.
Yeah, Dr. Koji, you want to share your slides? Is possible?
Is that okay?
Yeah, okay. So maybe just 1 or 2 slides on this topic.
Yes, just because I am representing the cardiovascular pharmacotherapy. Well, just I will speak about briefly about the antihypertensive drugs and COVID-19. And as already Dr. Zhou described, the hypertension is very common in COVID-19 patients. And also that the 48% of non-survivors had hypertension and 23% of survivors have hypertension. The odds ratio of hypertension for death is more than 3. And also in Europe, it has been reported that more than 70% of the died patients have hypertension. So the hypertension is very common in non-survivors in COVID-19. So maybe that the hypertension is also common in old, high-aged patients, but let's go to the hypothesis of the ACE2, angiotensin converting enzyme 2, which is actually the protective molecule, but which it has been also shown that ACE2 serves as a receptor for the SARS coronavirus 2. And also it is shown that the angiotensin converting enzyme inhibitors, ACE inhibitors, and angiotensin receptor blockers upregulate the expression of ACE2. So this fact led to the hypothesis that the patient receiving ACE inhibitor or ARB are more susceptible or more opportunity to be infected by SARS coronavirus 2. So there are a number of discussions for this hypothesis and against on this hypothesis. And for this hypothesis, the patient treated with ACE inhibitor or ARB may be at higher risk of COVID-19, and so that the calcium channel blocker could be a suitable alternative for the hypertension treatment. On the other hand, at present, it is unclear whether the hypothesis could be applied to humans. Therefore, ACE inhibitor or ARB should be continued until further data are available. But many societies is against for this hypothesis, including ESC, AHA, ACC, and Heart Failure Society of America state that at present there is no clinical or scientific evidence to suggest that treatment with ACE inhibitor or ARB should be discontinued because of the COVID-19. But very few data are available, but one published data is available on the use of ACE inhibitor and ARB. And the title of the paper is the cardiovascular implications of fatal outcome of patients with coronavirus disease 2019, COVID-19. And basically, in this paper, the elevated troponin T levels are associated with death. So if the troponin is high, the mortality is around 60%. And if the troponin level is normal, the mortality is around 9%. And with the use of ACE inhibitor or ARB, the high elevated troponin is 21%, and normal troponin level, the use of ACE inhibitor or ARB was 6%. This was significantly different. P-value is 0.002. And also the mortality rate, the use of ACE inhibitor or ARB was 37%. And if the patient did not receive this drug, the mortality is 26%. This difference is not significant. But the elevated troponin T levels in patients receiving ACE inhibitor or ARB might be attributable to that the heart failure patient often receiving this drug. So at present, we are not sure the elevation of the troponin T is attributable to the specific effect of ACE inhibitor or ARB, or due to the more often in heart failure patients are included in elevated troponin T groups. So this is a tentative conclusion, not conclusive, just a hypothesis. At present, there's no clinical evidence to show that ACE inhibitor ARB results in fatal outcome in COVID-19 patients. Right now, the clinical trials are ongoing, but we cannot rule out the possibility that these drugs will increase the susceptibility or opportunity to be infected by SARS coronavirus 2. So, and also the hypertension or heart failure are also common in high-aged patients. So these patients need to be carefully followed up on COVID-19. And lastly, this is my personal perspective to be discussed. If the patient, hypertensive patient is stable, I would say just to consider to change ACE inhibitor or ARB into other drugs. But the heart failure patient, and apparently there is a clear evidence that ACE inhibitors or ARB are beneficial for heart failure patients. So at present, we should continue this agent. That is a personal perspective, but we need further evidence for that. Thank you very much for your attention.
Thanks, Prof. Koji. That's very succinct. Can I just have a quick word from Dr. Zhou Ning? What is the practice in China? Do you switch the patients away from ARBs or ACE inhibitor?
Yeah, that's a very controversial topic. So we never stopped the use of ARB or ACI for those hypertensive patient or the heart failure patient of the COVID-19 patient. So we still continue to use these drugs in the COVID-19 patient. Yeah.
So there's no change in practice. I think this is consistent with all the major societal guidelines that I think the fear or this presumptive change may cause more harm if the hypertensive patient are not well treated. So I'd like to take one more bundle of questions before we move on to Dr. Ling's lecture, before I close up to address the other question. The next bundle, which I'll ask opinion from the faculty, especially Dr. Zhou, is how to tackle troponin T, BNP, and tying with ECMO use. For example, your patient clearly had troponin T as well as BNP rise and depressed LVEF. And in this group of patients, is the criteria more for VV ECMO to address hypoxemia or VA ECMO to address the cardiogenic component, noting that the pH was low, he was having high lactate. Clearly, he has some form of cardiogenic collapse as well. So when do you decide on VV versus VA? Do you do troponin T or I as a routine for all cases? And only if positive do the BNP, or is it routine for all patients or only for the sick patients? Dr. Zhou?
Yeah, that's a very, very important, also very interesting problem. So before we did the implementation of ECMO for the patient, absolutely we need to test the echo and the ECG and also the BNP troponin for him. So preferably, I use the VV ECMO for the very severe COVID-19 patient, because for the COVID-19 patient, the biggest problem is the respiratory failure. That means hypoxemia. So most patients has a very severe hypoxemia caused by the respiratory failure, but not the heart problem. Of course, the heart problem is very important. But for those who has a respiratory failure and a heart failure, evidenced by a very high BNP, a very significant myocardial injury, as the troponin and the troponin I or troponin T increased very much, for those patients, we would to change into a VA ECMO. But for my patient, I have 5 cases, just one VA ECMO, because his BNP is very high. It's over 10,000, over almost 1,000. No, 10,000, 10,000. So at that time, I would like to use the VA ECMO for our circulatory support for the patient. But according to my experience, VV ECMO may be better than VA ECMO for a very regular COVID-19 patient. Yes.
So it's also easier to use less mobility, and potentially you can consider a wake and then extubate this group of patient if the VV ECMO does the oxygenation well for this group of patient, more comfortable for them as well. So there's a lot of other questions just to find my faculty. They are talking about what is considered adequate PPE for frontliners. China has a lot of experience, and you have a lot of frontliners who are infected. And I think there's a lot of myths out there about what is considered adequate PPE. This part I will probably get Dr. Ling as well as Dr. Zhou, as well as Dr. Lam to share their experience about what do you feel safe as a PPE for healthcare workers. So we'll start with Dr. Ho first. In Hong Kong, what is a PPE that you think is adequate for healthcare workers?
Yeah, regarding the PPE issue, I think there are many experts. They will talk about that. Maybe I mainly focus on the PPE in cath lab in this issue. I've checked most of the PPE that we use in cath lab actually is level 3. Suppose it's water resistant, but this is just water resistant. It's not waterproof. If you put some water over it, it's okay, the water will not go in. However, if you have prolonged contact time with the blood during the PCI inside the lab, maybe also in other clinical work, when you have prolonged contact time with liquid, actually water or blood can cause your PPE. That is something you need to be very careful. Many of the time we take the PPE, go to do the PCI, and then after that, after the gun and then the supporting staff will find some blood on our apron. So be careful of that. The PPE is level 3. prolonged contact of water, liquid, it can diffuse inside your body. That is something I recently found out.
So Bolam, just to clarify, your PPE is a N95 mask, mask over your eyes, full gown, and right?
Yeah. If we do
PAPR or no?
If we do suspect case, we will use N95 and plus face shield, and also a cover of the hair, everything.
But not a hazmat suit,
just,
right? Only a hazmat suit, just a gown. Mm-hmm. No waterproof gowns in Hong Kong. Just
no, so far no. Now our strategy is try the best to avoid to do PCI for confirmed COVID case or suspected case. Try medical treatment unless you can.
Dr. Zhou, sorry.
Yeah.
Dr. Zhou, you want to share on the PPE in China for the frontline stuff? We can't hear you. Are you muted, Dr. Zhou? I think you're...
Yeah, very similar to Dr. Lam in Hong Kong. We use the very strict infection control in the cath lab and also in the ward. We just finished 2 cases of the STEMI patient with a COVID-19 patient in the cath lab because of the very severe condition, because the patient have a cardiogenic shock. We did the thrombolysis for him, but the circulation is still very bad. So we have to choose the PCI for him. We don't have the negative pressure cath lab so far. So just to reconstruct our cath lab to prevent as much as we can to protect our medical personnel working in the cath lab. We close the AC. We close the AC. We shut down the AC. We close the windows, the doors, and seal them. And also we use the third grade protective method. That means that we use a protective suit. We use the N95 mask, and also with another surgical mask covered the N95, and also the goggles, the waterproof goggles, and also the face shield. And then we covered every skin of their body. And in this case, I think we can decrease the possibility to be infected as much as we can. But I don't think that the regular PCI for the STEMI patient is a good choice for our cardiologists, because we cannot to make sure that we cannot be infected in the cath lab, because the cath lab is a very small room. The airflow is not so fluent. So I think that's a very high risk for us.
Yeah, I think Dr. Bolam previously shared also the problem across all cath lab is a positive pressure. I think China showed us some example where they built barriers at the exit to prevent it, because actually the moment the door opens, everything is aerosolized in the control room, outside, and the circulation, you can't really. So I think it's very tricky to do COVID positive patients. I think a lot of countries have moved on to thrombolysis if appropriate for the STEMI patients, and only in hemodynamic unstable patients for the ACS patients do we bring a COVID patients into the cath lab. There are a lot of repercussions for staff.
Can I just make a comment?
Yes, Dr. Koji.
Yes. Many people are asking about the elevation of the troponin level and also myocardial injury. So I'd just like to ask Dr. Do, is it very easy to differentiate myocarditis and acute myocardial infarction due to coronary thrombus? Because in most patients, the troponin elevated, and also some kind of change of electrocardiogram will occur. So it may be very difficult to differential diagnosis of myocarditis and acute myocardial infarction due to coronary thrombus.
Excellent question, Prof.
Do you have
Dr. Zhou, do you have any answer to that one?
Yeah, I fully agree with Dr. Kochi about the differentiation of STEMI and the increased troponin I or troponin T induced by the hypoxemia, because that's very difficult for us to do the angiography very emergently. So we used the echo, we used the ECG, and also we use other kind of the examination to differentiate why the patient have a myocardial injury. Is due to the primary coronary heart disease, or is just a secondary phenomenon caused by the hypoxemia or the infections. So that's very difficult for us to differentiate. So it need a very comprehensive judgment.
Do you see in those troponin positive patients ECG changes of pericarditis or ischemia, or is it very non-specific?
It's not very so common. I mean, we already finished the analysis of the patient with a normal ECG when they has a very high troponin I, and we found that around 30%, only 30% have a ST elevation, but most of them are ST depression. So, you know, ST depression doesn't make many sense, because the hypoxemia infections and the other kind of the like heart failure, some patient with heart failure can also have a ST depression. But for those has ST elevation, we need also think furthermore, like, is it a myocardial infarction or is it a myocarditis? You know, a lot of myocarditis can also have a ST elevation, especially for those familial myocarditis. You know, this patient is a inflammatory storm. The inflammatory storm can also lead to myocarditis, especially for those very young patients. Be very, very careful. If you find a ST elevation in a very young patient and the troponin is extremely higher, so be careful. Maybe it's a familial myocarditis, because the differentiation of familial myocarditis is very difficult, especially for those you cannot tell whether it's a myocarditis or whether it's a coronary heart disease. That's very difficult to tell it.
There's an interesting question from Alan from Malaysia, addressed probably to Dr. Zhou. So, you know, Wuhan now is lifted its lockdown, and of course, everyone is waiting to see whether COVID can get back to China again. What are the measures? For example, do you PCR test every case that comes to your cardiology clinic, or for elective PCI now, for elective surgery? Do you do routine tests for all patients requiring procedures now, even if they're well?
That's very interesting. So far, we already returned to our regular clinical work. So at this time, for any patient who need to be admitted into our ward, they need to be tested by the virus as well as the antibody before the admission. That's just for sure they are not the asymptomatic infections. You know, some of patients who actually is a virus carrier, and this patient is also infectious. I don't know how infectious they are, but they are infectious. So to prevent the spread of the virus, we need to be very, very careful to do as much as we can for the virus test for those patients. And
so China
yeah, that's also very important
test.
for the production of the medicine. Test as much as we can.
So I know China function on test, and I think Ho Lam tells me Hong Kong function on mask. Everyone must put on a mask as well. Anaruk from Thailand is asking about, just to clarify, Dr. Zhou, positive pressure in the cath lab. So you shut down the positive pressure and do full PPE before you do COVID patients? Do you turn off the positive pressure in the cath lab before you do patients COVID positive, Dr. Zhou?
You mean turn off what?
The positive pressure in the cath lab. Do you shut it down?
Shut it down. Yes, shut it down.
Okay, so you shut it down. Okay, good.
Yes.
I think there's actually a lot of questions that I think we'll just take one more from Dr. Kenneth Wu from Singapore, asking, should we do ECG in all patients who are under the swap and send home program? Dr. Ling, do you want to take that one? Should we do ECG for all the patients who require URTI, febrile, swap and go?
No. I mean, of course we have to look at the patient. I mean, the quick answer is no. But you got to look at the patient profile, right? If it's an elderly patient with multiple comorbids and if there is any evidence of cardiac symptoms, then yes. But if it is a young person and quite a lot of our COVID patients in Singapore are fairly young without any comorbids, then there's no reason to do routine ECG just because they come in for acute respiratory symptoms. Yeah.
There's this other side track question. Any precautions to be used during autopsy?
Can I have one question?
Yes, please, Prof.
Yeah. Yeah. Do you have? Is anybody have data on the antibody against the COVID-19? So many people will check the COVID-19 PCR, but Europe or America are going to use antibody checking.
So this is a great question. Dr. Ling, do you want to take that? What's the value of serology on top of swabs?
Yeah, so far so we have done some testing, and so to summarize some of the findings that was found was that, so for serologies, you've got IgM and IgG, okay? So for diagnostics, really, I don't think, this is our take on it. For diagnostics, meaning that to diagnose someone as a new COVID patient, especially if it seems to be within the first 14 days of symptoms, the serology has not performed very well. The sensitivity ranges for IgG is less than 50%. For IgM is maybe about 80% towards the end of the 2 week. But if it is, say, beyond 2 weeks of symptoms, okay, and say your PCR is continuously negative, then there might be a role for serology because the IgG positivity beyond the 12 to the 14 days of illness rises quite significantly to close to about 100% sensitivity. So to summarize it all, if it's very early on in disease within the first week, probably no point doing serology. You're not going to get a positive result. And even if you didn't get a positive result, if you got a positive, good. If you got a negative, it doesn't exclude. But say if we fail to diagnose the patient with a positive PCR and is still symptomatic beyond 2 weeks, or the clinical picture is very like COVID, as in PCR negative, got fever, CT shows nodules, it's 2 weeks of symptoms, yes, proceed with the serology.
So I think in the future, for places like Wuhan, where there was high prevalence in the population, maybe beyond screening Hep B, HIV, they need a IgG COVID antibody to come in safely back to the hospital for procedures. So I think we have a lot of questions, but I want to give some time especially for the Singapore audience and whoever is interested in the Singapore data, for Dr. Ling to do her presentation, to share the Singapore experience and some of our cross-sharing in Singapore. Dr. Ling, will you be okay to share your slides?
Yep, okay, so I share my slides now, yeah? Hang on.
The questions were coming fast and furious, so the Q&A took a bit longer, but we'll spend the next 10 minutes or so for Dr. Ling to just share across the Singapore experience as well. Then we'll see whether there are any more questions that we can group together and take. And of course, my faculty, Prof. Koji gave a lot of good questions, and Ho Lam and Dr. Cho, you can discuss among ourselves as well as Dr. Ling puts up the slide.
I don't know why, but I cannot seem to find my slides. As in,
No,
we did a practice session
I'm going to
yesterday.
take other questions first. Is there any difference? Do you have any precaution when you do autopsy for the patients in China? This question was quite interesting and it popped up. I don't know whether Dr. Cho, you have are the patients double-backed, or they don't do autopsy on this group of patients who dies? Dr. Cho, are you muted or okay? Dr. Cho?
Excuse me. I can hear you right now.
It's okay. So I think Dr. Ling's slides are up. We'll get Dr. Ling to present first. Yeah.
Okay, thank you very much for your invitation. I'll try to go through these slides as quickly as I can, so that there's
full screen sharing. Maybe you can go
full screen sharing. This is a PDF.
Oh, PDF, it's okay. It's all right.
Is that okay? Let me go and find.
That's fine.
Okay.
Yeah, go ahead.
Yeah. Okay, so I'm just going to This is the outline of my talk today. We'll just give a brief situational update of what's happening in Singapore, some profiles, a descriptive analysis of some of the profiles of cases that we've seen at NCID. We'll also discuss a little bit about chest X-ray changes in some of the sicker patients, as well as viral shedding overall. I'll discuss a little bit also about the experience with cholinergic and interferon that we've had so far. And then maybe just to describe the incidence of hypokalemia and some cardiac complications in the ICU patient. So I have to say it's fairly timely that Singapore had NCID, National Center for Infectious Diseases, built to help us manage our fight or battle against any pandemic. So it's really timely that we had this, because this building really was officially opened only from September 2019 onwards. Okay, so very timely for this pandemic. Now, in terms of the facilities that we have, there is about 64 cohort beds with 100 isolation beds and 124 NEP beds, okay? Certainly, these are all scalable such that in the event that we need more beds, they could be double-decked, so 2 beds in a single room, to such that we may be able to accommodate more than 500 patients that needs to be isolated. Okay. Situational update, so this is updated as of 14th of April. Up to that point in time, we had about, in total in Singapore, 3,252 cases, of which about 1,500 was admitted to NCID. The rest were admitted to various public hospitals as well as a few private hospitals. In terms of age, the median age is around 35. I think at this point in time, this median age has been brought down simply because of the fact that we've had dormitory workers, there's been clusters of dormitory workers affected, and a lot of these dormitory workers are fairly young. Their median age ranges between 20 to 40 thereabouts, okay? And therefore, it's not surprising that our percentage of males affected have also gone up to about 77%, okay, of which 82% are locally acquired. Now, looking at the number of patients that required ICU, so this is updated until 14th of April, about 2% required ICU, okay, and they stayed for a median of 6 days, and this was looking at 24 ICU patients. Symptom onset to ICU admission was about 8 days. Symptom onset meaning respiratory symptom onset to ICU admission was about 8 days. Okay. Symptom onset to oxygen requirement. So from 9 days from respiratory symptoms to requiring oxygen was about 9 days. What about the incidence of abnormal chest X-ray? So we looked at the first 177 patients, about 3.4 on admission didn't have X-rays, but subsequently they did. So for these patients, the first chest X-ray, about 2/3 initially had a normal X-ray. Okay, subsequently, they did progress to abnormal X-ray. Now, in terms of what was the percentage of people that had normal or rather abnormal X-ray, I just wanted to point out that in the younger age groups, right, even when they needed oxygen or when they were in ICU, their very first chest X-ray, so say people in their 30s, 25% that required oxygen, had only 25% had abnormal chest X-ray, okay? And 13% of our ICU patients in the younger age groups, their very first chest X-ray was actually abnormal, only 13%, okay? But subsequently, as their progression went on, yes, they developed abnormal chest X-ray, a higher percentage developed abnormal chest X-ray. But as you can see in the older age group, so in the 60s to the 70s, upon presentation, a much higher percentage had abnormal chest X-ray. So just wanted to point out that it is not uncommon that for some of our younger patients, when they have respiratory symptoms and they come in, they may actually have normal chest X-ray. But if your clinical suspicion is high, say they have mild thrombocytopenia or they've been living in a cluster of COVID patients, please do the testing and do serial chest X-ray to monitor for progression. Now, this is some data that is that Barnaby Young and his group did. Barnaby is one of our ID consultants, and the manuscript's been submitted for review. So he reviewed the first 100 Singapore patients with COVID who were symptomatic with or without chest X-ray changes and hypoxia. And if you look at fever, dyspnea, and sore throat, that was significant. So for those without pneumonia, on presentation, 60% had fever. On presentation without pneumonia, 7% was dyspneic. Without pneumonia, 67% had sore throat, okay? Comparing to when they had pneumonia, but without hypoxia, well, when they had pneumonia, a much higher percentage had fever, same with dyspnea, and the sore throat declined in percentage. And when they had hypoxia, the percentage of those with fever was significantly much higher, 95%, dyspnea, 40%, and the incidence of sore throat and rhinorrhea also dropped. And this difference in these percentages was significant. Now, so what were some of the predictors for severity for patients that would subsequently develop more severe COVIDs? So Poisa Horn, one of the intensivists at NCID, did this review, and he submitted it also for manuscript review. He found that in ICU patients, so the people who tended to be more unwell, they tended to be older. On presentation, they tended to report dyspnea, and they also were found to have a lower SpO2 on presentation with higher neutrophil counts. And so what were some of the markers that would raise the alarm bells that if patients were of this particular category, there is a higher chance that they would develop disease progression with COVID? Well, in particular, if the age is more than 50, if they had chronic comorbidities, if they had symptoms such as dyspnea, lower SpO2, chest X-ray with pneumonia, and if the CRP was greater than 60 and LDH greater than 550, lymphopenia, neutrophil count that was elevated, a bit of thrombocytopenia, elevated TROP-I. So I'm moving on to our treatment guidelines. So this was discussed and carved out by a group of ID doctors from various hospitals as well as key pharmacists. So the take home from our COVID treatment guidelines is that if patient is considered of a high risk of progressing to severe disease, but is currently not so severe, and it's early on in the days of illness, we will enroll in an RCT, a clinical trial first, okay? But failing which, if they're not eligible, then we'll consider them for Kaletra and with or without interferon, hydroxychloroquine, or we just observe, okay? Now, if they had presented a little bit later and they were more than 7 days from onset of illness, yes, we'll still try to enroll them in a clinical trial, but failing which, if they're not enrolled, we will do pretty much the same thing. Whether or not we offer convalescent plasma, well, plus minus. Now, if they're already in ICU with severe disease, then yes, we will try to still offer clinical trials, but we'll try to recruit them into the severe Gilead trial, whereby there's a 100% chance of getting remdesivir. We may consider convalescent plasma, but this has to be in a multidisciplinary discussion with ID, immunologists, and intensivists. It's certainly not treatment that we take casually. Now, if we feel that this is the second week and there's evidence that there's hyperinflammation syndrome, such as very high CRP, very high ferritin, and high fevers, we may firstly do an IL-6 level and consider offering tocilizumab. Again, discussed in a multidisciplinary setting. Now, we have had the most experience with Kaletra and interferon 1B for our initial first 100 cases. So Grace Hu, one of our pharmacists, looked at the first 43 cases, and this is what she observed. Most of these patients, about 50%, were started on Kaletra within 7 days of symptoms. About 40% was also an interferon, okay? The median duration of Kaletra therapy was around 8.5 days. The median number of doses of interferon was around 3. Ideally, if the patient is able to tolerate it, we try to give them 7 doses over a period of 2 weeks. In terms of adverse side effects experienced by the patients, mainly a lot of GI side effects, okay, as well as abnormal LFTs, okay. So what were the types of LFTs? As you can see, majority had just grade 1 LFT abnormality. So the ALT and AST is about 1.5 to 2 times upper limit of normal. A small percentage had grade 3 or more. We're looking at more than 5 to 10 times upper limit of normal in terms of the LFTs, including bilirubin. So we even have had patients whereby the bilirubin went up to about 100 plus to 200 on Kaletra alone. And after we stopped Kaletra, the bilirubin just gradually came down over a period of a few days to a week. So next I'm going to talk about COVID viral shedding and CT value. So this concept of cycle threshold value is such that, so Barnaby in his study, he found that at a threshold, at a CT threshold of 30 and higher, the amount of genomic sequences that could be sampled from a swab becomes almost negligible. So it almost implies that the patient is not infective, very little virus left, okay? So we certainly have observed that with zero CT values is that the higher it is, the better, fewer virus there, and it tends to rise with days of illness from date of onset of symptoms, okay? And the rate of decline also varies with degree of illness severity, or the rate of increase also varies with degree of illness severity. So what we found was, as you can see here, 30 is the magic cutoff number. So if the CT value exceeds 30, it tells us that the amount of virus is probably very, very negligible. And if we cultured it, we may not get anything, okay? And if we try to correlate that with whether or not the patient had pneumonia versus no pneumonia, or whether or not there was pneumonia with hypoxia, you will find that the patients with pneumonia, by around the end of the first week of illness, their CT value would have exceeded 30, meaning that they are probably not so infectious, okay, or maybe, or rather, very little virus left if we did their MP swabs. However, for people with pneumonia without hypoxia, their CT value took a little while longer, up to about 10 days before it became higher than 30. Now, for those that had more severe illness with hypoxia, you can see that it took right up to 21 days and some of them still had a CT value that was less than 30. Okay. So what does this mean for us in terms of clinical interpretation and implications for us on the ground? So how we take this is that, how we interpret this is that usually at day 15, about 58% of our COVID patients will be PCR negative. So 58% could be discharged or de-isolated, okay? By day 28, 95% of our COVID patients would be PCR negative, and therefore 95% could be either be discharged or de-isolated from COVID wards. Okay, finally, last 2 slides. How about potassium? We have observed amongst ourselves quite a lot of low potassium in many of our patients, including the young ones. And when we talk about low potassium, a lot of them have potassium that's less than 3.5. And so you look at the percentages, the percentage of patients with potassium less than 3.5 ranges between around 29 to 60%, tends to occur at a higher percentage with the older age groups, more than 60. We can't explain why. There's not a lot of nausea and vomiting with these patients. Some do have diarrhea, but the diarrhea is not significant and neither is it prolonged. So we really do not know why they have low potassium. And what about cardiac complications? So on the general ward, about 80% of our patients are very well. Cardiac complications are not hardly seen actually on general ward patients, but in ICU, we probably see it the most. So personal communications with Poisson, one of our intensivists, whereby he looked at 50 ICU patients. He tells me that out of this 50, 2 patients had atrial fibrillation, okay? 4 patients were diagnosed with a non-STEMI and 2 patients were diagnosed with a type 2 MI, okay? Only 5 patients had a 2D echo done, of which their EF ranged between 40 to 60%. Okay. And the range of TROP-I, if it was ever done, would be between 28 to 6,000, and this was only done in 17 patients. And if this was done, it would be done usually in the first week of ICU, and when you're symptomatic, so chest pain or hypotension, for instance. Okay, I'm going to end here. This is the last slide. A lot of the data that you see up there today is all collated and analyzed by these various colleagues from National Public Health and Epidemiology Unit at the NCID. I'd also like to thank Dr. Sean Vasu and Dr. Wong Chun Seong for the additional slides. And I'd like to cap off by saying that I definitely agree with Dr. Zhou. You know, it is all about teamwork when it comes to battling the COVID infection. And we are so very grateful for the amount of support we've been getting from everyone in Singapore. Thank you.
Thank you, Dr. Ling. That was fantastic. There's better elaboration compared to this morning's quick teleconference with Professor Liu as well. So can I say that we have maybe another 10 more minutes to go before I would like to close this session. I'd like to address most of the questions, especially those directed at Professor Zhou, because I think he has leave sharp at 1:30 for another engagement as well. One quick question, do smokers have a more severe disease progression, Dr. Ling or Dr. Zhou? It's a good time for anti-smoking campaign, right?
That's very interesting because according to the former observation, we don't think that the smoker is more susceptible and more
Please
severe.
don't say that. You should say they are susceptible. Sorry.
But we don't have that data, you know, should be scientific. Yeah,
okay.
theoretically, the smokers are maybe more susceptible to the coronavirus, but we don't find any very solid data to support that the smoker is more susceptible. So be science. Hopefully, we
so so far the hypertensive patient seems more susceptible than smokers. Professor Koji, any comments to that, or Ho Lam?
Yeah, I'm very surprised to see the last slide of Dr. Ling that out of 50 patients and 6 patients had a myocardial infarction. It's very high percentage. And how about in China? Do you have so many experiences of myocardial infarction in COVID-19 patients? And it's very frequent, and inflammation may occur at the coronary artery, and which cause the rupture of the unstable plaque, which led to the thrombus. Do you think that is a mechanism of the acute myocardial infarction in COVID-19 patients?
Dr. Zhou, you have any comments?
Yeah,
what's the percentage like in China?
Just finished the raw data analysis yesterday. So our percentage of the acute myocardial infarction in the severe COVID-19 patient is around 1.3%.
1.3%, okay.
Yeah, 1.3%.
Still, I think it's very high and higher than the usual percentage, even 1.3%.
Yeah, so 1.3% of all the sick cases or all cases? 1.3%.
All the cases in my hospital. We have 1,400 severe COVID-19 patients in my hospital.
How about what percentage in the ICU patients? What is the percentage of type 2 MI based on enzymes in the ICU group of patients? Do you have data for that?
We don't have very exact data in the ICU board. From February 10 to 31 March, we have 4 acute myocardial infarction patients in the ICU ward. During this time, we have over 70 patients monitored in the ICU. So 4 plus
4 out of 70.
70, yes.
Okay.
That's ICU ward.
Dr. Lam, you have any data?
Yeah, may I ask some question? Because I see Dr. Ling's slide also in Singapore. I think that maybe you also use hydroxychloroquine. May I ask Dr. Ling and Dr. Zhao, what is your experience with the hydroxychloroquine? Do you think it works? The drug hydroxychloroquine.
Yeah, I have to say that we've only started to use hydroxychloroquine in the past 2 weeks. So we do not have, I do not really have enough experience to say that it works. Honestly, I think, I don't know if it's going to work.
Dr. Cho?
Yeah, as I said, I used the hydrochloroquine in the ICU ward during the past 2 months. It showed that the hydrochloroquine might help for the severe or critically severe patient, but may not help in the mild patient.
Actually, to tell the truth, I don't know. You see the treatment regimes, the way it's segregated, it seems as if people are saying we should start earlier rather than by the time they're sick. And I'm not too sure whether there's a lot of evidence backing which drug to start early versus late. And I think there's a lot of questions here about treatment, convalescent plasma, the role of prophylaxis for COVID exposure. I don't think we have enough data to, you'll be opinionitis here, so I'm very hesitant to give more guidance on therapy at the moment. I think we should focus, I think I would like to quickly summarize and then get everyone to say one last words, that we should focus on what we do know, which is that it's really a pandemic. We do need to test, and really isolate and quarantine the exposed group to prevent further spread. So flattening the curve, like what China did, what Korea did, maintaining a low rate of infection, like what Hong Kong is doing, or what Taiwan is doing in these East Asian countries, is what everyone should be aiming for. We shouldn't have a doubling rate of 2 to 3 days like the US or parts of Europe. That's the first thing. I think previously Ho Lam keep talking about mask. So Singapore now is following suit. When the prevalence rate is high in the community, everyone should be masked up, protect themselves. I think that's fair. I think the healthcare workers and the community should band together to help with the effort. I think we are really frontline. And because we're frontline, the adequate PPE and personal standards of care should be enforced. We should really take good care of not just ourselves, but our patients, as well as a team. Every time the rates of infection goes up, my fear is collateral damage for our cardiovascular patients. When the system is overwhelmed, I can't treat my AF patients, I can't treat my AMI patients well. So I would ask everyone to prevent more infections by watching out for this group of patients, so that we as cardiologists can continue to manage our patients. Before we jump onto postulated mechanisms and treatment strategies like stopping ACE, ARB, I agree with Professor Koji, we should get more data first before it causes harm by prematurely stopping proven efficacious drugs, or prematurely jumping on bandwagon to push for convalescent plasma and all this. Every treatment has risks, especially in some of the more elderly patients. I think some of the antivirals and hydroxychloroquine can potentially cause harm in our cardiovascular group of patients. So with that, I'm going to go around and get everyone to summarize. We'll get Professor Zhou Ning to say something first before he leaves. Professor Zhou?
Yeah, sorry, because I have another webinar at 1:30, so I'm so sorry for the because thank you so much for having me here, and it's my great honor to share my experience. Is better or is good or is bad? I mean, the greatest concern of mine is to keep ourselves safe, right? So I hope everyone, especially for the frontline medical doctors like Dr. Ling, Dr. Ho, and Dr. Koji, please be sure to keep yourself very safe, and be sure to wear the N95 mask before you have a very close contact with confirmed or highly suspected cases. So that's very, very important. Before you take care of the patient, to protect yourself very, very well. That's what I want to say and want to share with you. Thank you so much.
That's coming from personal experience or somehow it's recovered from COVID. Dr. Lam Ho, you want to have a final word?
Actually, thank you, Jack. It's my honor to be here, and I'm very thankful and grateful to learn from all the experts. And very fruitful experience this time. Thank you.
Thank you. Dr. Ling, your concluding
got nothing.
remarks.
Very grateful for this opportunity to actually share and learn with everyone. I've learned really so many things just by listening to your comments alone. I can only just echo Dr. To. That seems to be what I'm doing today, echoing what his sentiments. Yes, we have to protect ourselves. And I know somebody just recently reminded me that even if a patient is collapsing in front of you, do not rush in. Make sure that we have the correct protection, make sure that we're properly protected, put things on properly. It takes time to do that before we go in, because as frontliners, you know, if we are down, it doesn't do anybody any favors at all. That's all.
Professor Koji, your final concluding remarks.
Yeah, thank you very much for all. Discussion was very nice, and China, congratulations for China already overcome the COVID-19. Now the other part,
Yes.
the COVID-19 infection is increasing, so we need to learn a lot from your variable experiences. Thank you very much.
So again, I'd like to end by thanking all the callers. I think we had 5,000 call-ins and almost 450 stayed all the way to the end now. And that's quite amazing. So you guys, the faculty, as well as the presenter, Professor Zhou and Dr. Ling and Professor Koji has done a wonderful job engaging the audience. So I'd like to thank my faculty, thank the participants, and again, thank Roche for collaborating with APSC and ISCP to jointly organize this educational webinar. We hope to do more useful webinars for the participants. So please log in and give us a suggestion on how to improve on this webinar and the type of topics that you want us to focus on. So with that, I would like to thank everyone. Keep safe, mask up.
Okay.
You can smoke now.
Okay.
Tobacco is safe. Well, thank you very much, guys. Bye-bye.
Thank you very much.
Thank you.
very
Bye.
much.
Bye-bye.
Thank you.
Bye-bye.
Bye.